we have a major problem that a small percentage of patients, they go for a relapse. We have a consensus for the primary treatment, but when it comes to relapse, we have a lot of difference of opinion. And today, this webinar is going to focus on that controversy or that confusion which we have about what is the best management for the relapsed clubfoot. We are really fortunate to have 4 continent experts with us. The first speaker of the today's webinar is Jose Morcuende. I'm going to introduce him shortly. Then we have a Christof from Europe. John and Viraj are from Asia, and Monica is from Latin America. So let me give a short introduction of them. Jose Morcuende is at present a professor at University of Iowa, but he did his undergraduate and postgraduate study in Madrid, Spain. After that, he migrated to USA in 1991, and again he did a residency program at University of Iowa. And from that journey, from the residency, at present he is a professor at the same place. His major practice is concerned, 75% of his practice is related to clubfoot, and he runs clinics of clubfoot 3 times in a week. So he has a huge number of patients of clubfoot. In addition to that, he has another interest, and that's a musculoskeletal oncology. He is the executive director of POSI International Association. So I'm sure that he has learned this technique from the master, and he has taken the practice of masters also. So he's going to share most important tips which we are not knowing at this stage. He's going to tell us that also. The second expert panelist is Christof Radler. He is head of pediatric orthopedic at Spessing Hospital, Vienna, Austria. Again, he has a more than 20 years experience in managing this deformity. He said that he has the largest clubfoot clinic in Europe. He is also advisory board at POSI Internationals. And in addition to clubfoot, he has an interest in congenital limb deformity and gait analysis. Another doyen of pediatric orthopedic is from India, Dr. John Mukhopadhyay. He is director and head of the department of Paras HMRI Hospital in Patna. He is chairman of Orthopedic Research and Education Foundation, which is on a forefront of spreading the education all over the country. He is also a member of Pediatric Fracture Group, expert group of AO International, and he has also written chapters on the clubfoot management. The Monica Nogueira, she is from Sao Paulo State Hospital, and she's associate professor over there. He is also advisor of POSI International Association and a past president of POSI Latin America Group. She has also done a fellowship in limb lengthening and deformity correction from Baltimore. The young dynamic pediatric orthopedic surgeon from Nagpur is a director, that's Dr. Viraj Shingade. He's a director at Children Orthopedic Care Institute in Nagpur. He runs an NGO, non-government organization, and he provides free rehabilitation service to almost 4,000 children. And he also carries out free surgical camps. He is a 2 major contribution in the field of pediatric orthopedic, that is 1-stage osteotomy correction for the neglected clubfoot and a surgical treatment of congenital radioulnar synostosis. So with these 4 experts and 1 guest lecturer, we are going to have a good interaction. Just those who are on the, watching this webinar on the YouTube, they can WhatsApp their question on the number 733-9414-779. And the last thing is about the next webinar. On the 6th November, we have an interesting webinar on the upper extremity problem in cerebral palsy. And we have an expert from Boston Children's Hospital, Carly Willerbein. She is going to talk on the same thing. And we have 2 great experts on the field. That is Peter Waters from Boston Children's Hospital and Mary Beth Izaki from Dallas. So they are going to share their expert knowledge for this webinar. So please take a note of this webinar. So now I will stop sharing. I will request Taral to tell you something about the poll, and then I will run the poll.
So in India, we always start everything with politics and poll, and this webinar is no different. We want to have the public opinion, what people feel about a given condition before they are taught. So I would request Dhirenbhai to start sharing slides, and after he has shared the question and the possible options, I will give you the options on the poll, and people can poll. You will have 20 seconds to poll, and then Dhirenbhai will give his expert comments, and then we'll proceed on. So there are 5 questions, and we'll do them one by one. Dhirenbhai, over to you.
Yes, so there are 5 questions, and each questions there are 4 options. So you just have to select one of the option. So it's very easy, but this is going to be very interesting because it will give us idea about what we think before the webinar. So the first question is, according to you, what is the most common cause of relapse? A, inadequate correction. B, improper brace. C, poor compliance for the bracing. And D, genetics of the condition of a child. So now it's open. You can give your vote.
There is a very close contest. Of course, the winner here seems to be poor compliance for bracing, but other are in close contest behind. People should vote. 5 seconds more to vote, and then I'm going to close this vote.
Okay, so like the majority of the participants, they feel that the major reason of relapse is a poor compliance of brace. It's a human tendency of an orthopedic surgeon, not an orthopedic surgeon, any human being, to blame someone else. We don't take a responsibility on ourselves, and we usually blame that it's a parent's fault, and because of that there is a relapse. But fine, we will see what is the opinion of our experts. Okay, shall we go to the next question?
Yes, sir.
Yeah. So question 2, in your practice, how frequently you see relapse by the time child completes the age 4? Usually we stop bracing at this year, at that stage. So by that time, the first option is in a less than 5% of cases. Option B, between 5 to 10% of cases. Option C, between 10 to 20%. And option B, more than 20%.
So exercise your right.
Oh, a real close competition.
5 more seconds to vote. Please keep voting, everybody.
So basically, like the A, B, and C, 1/3 of the participants, they feel that in less than 5%, 1/3 of them, they feel that it's between 5 to 10%, and 1/3 feel that it's between 10 to 20%. Okay, so we go to the third question. This is really interesting and okay, so a 6-year-old child has relapsed clubfoot. Your treatment will be option A, Ponseti treatment. This child was treated well, and after that there is a relapse. So option A is doing a Ponseti technique again. Option B, posteromedial release or a soft tissue release. Option C, posteromedial release plus osteotomy. And option D, JES, that's a Joshi's
experiment and epidemiology.
Yeah. Okay, so almost 75% of the participants, they will go for a Ponseti treatment. However, there is almost 6 to 15% they go for soft tissue release plus osteotomy or external fixator. Okay, the next question, that's question 4. What percentage of clubfoot cases required tibialis anterior tendon transfer in your practice? Option A, less than 5%. Option B, 6 to 10%. Option C, 11 to 15%. And option D, more than 15%. Okay, so the majority is like 41% says that in their practice, 6 to 10% of the patients they required tibialis anterior tendon transfer. However, there are like 16% and 13% they say that more than 15% of the cases also require this surgery. So that says that relapse is a really big challenge for us. And the last question, at what age do you consider tibialis anterior tendon transfers?
There should have been one more option, never. No,
Never, okay. Okay, so this is the result, like 50% of the participants, they say that they go for this surgery between 3 to 4 years. Okay, so with this, we end the poll over here, and now it's over to you, Jose.
Thank you very much for the invitation. This is a real honor and a privilege to participate in this webinar. Thank you to the participants for being here, and I hope that this webinar helps to, with the treatment of relapses, which is, as we know, is one of the main challenges in the treatment of clubfoot. I would like to thank also the organizers, and especially Monica Nogueira, Dr. Nogueira, and Dr. Christof Radler for joining into this webinar for their expertise on the treatment of clubfoot and relapses. I wanted to, when I was thinking about the topic, I thought about, do we really understand clubfoot? And I put clubfoot in quotes, and we will see why, and the Ponseti method. And this is based really in 65 years of experience from Dr. Ponseti first papered up to today. I have no disclosure other than I am founder and board of directors of the nonprofit Clubfoot Solutions. So it's important to recognize Dr. Ponseti because he was the person who really changed the paradigm of how we treat clubfoot today, but not just because of the treatment per se, but also because of the understanding. And we all know that his paper in 1963, in which he described his treatment and also described his main problem at the time, which was relapses, really was not understood by the community, and the papers after on this biology and biomechanics of the foot were not well understood, as we all know. And I think until his book was published in 1996 with his really philosophy of clubfoot understanding and treatment, that the community didn't start learning and really start changing the mind for how to treat clubfoot based on the basic concepts. So it's very important that we recognize his amazing contribution and really a gift that give us for treating these patients that are so common in our practices. And I think one of the main issues here is how do you conceptualize clubfoot? We are all familiar with most people in research have done dissections of the foot and trying to understand where's the problem in the foot. We as orthopedic surgeons are very concentrated on the imaging and how the bones look like. And then there are many hypotheses thinking that, when you do a dissection, and this is the classic picture by Dr. Ponseti, you can see that the navicular is completely displaced, is misshapen, The talus is also misshaped, and the midfoot is misshaped. And the issue here is that just because these tissues are misshaped doesn't mean that is the central point of the biology for clubfoot. As Pirani beautifully demonstrated in the study in 2001 with MRI, you can see here that you do the MRI before the treatment starts, and it's the same pictures like the specimen. And then 3 weeks into the treatment, the navicular is already starting to be in position and changing a little bit the shape, and the talus changed the shape. And then by the 6 weeks of treatment, the bones behave normally. And the fact is that in a study that they did, the amount of growth on the talus, specifically, it was 4 times the normal side, just because what happened is these osteocartilaginous structures were just completely constrained. And we know that when cartilage is constrained, it doesn't grow very well, and the same is bone. So the biological abnormality in clubfoot is not in the bones. And kids with clubfoot has no leg length discrepancy other than 10% that might have 1 or 1.5 centimeters. So there's no biological abnormality in the bones in the foot. What you can see, and clinically you see this frequently, is that when you see these patients, either from day 1 to adults, there's a difference, especially you notice that in patients with unilateral cases in which the leg is a little bit thinner. And when you look at the specimens of patients of clubfoot, you can see that the gastrosoleus, and this is smaller, and look at the Achilles tendon. In the normal side is very thin, and maybe 20% of the length of the complex of the muscles and tendon. And the muscles are very nice and well developed. In the clubfoot side, the tendon is very thick. It's almost half of the complex muscle tendon, and the muscles are very small, and also has some kind of fibrosis like in between the fibers. And that is what when Dr. Ponseti and other studies have done and evaluate these muscles and soft tissues, and found that there's an increased cellularity and increased amount of collagen. And it's also some collagen in between muscle fibers. So what happened in clubfoot then is not that there's a problem with the foot. It's not a problem with the shape of the bones, that they do respond to the mechanical stresses and they recover after the treatment. Is that there's an abnormality in the soft tissues and muscles on the lower extremity. In this study by Ippolito, which a fellow with Dr. Ponseti in the 70s, a professor in Rome, they did a very smart study by doing MRIs. And this is an MRI of a newborn baby, no treatment. And you can see here that the amount of muscle and the characteristics, the MRI characteristics of the muscles are very different between the normal and the athletic side. I mean, it's about 30 to 40% smaller. And if you look at the anterior tip, it has a lot of white around. The extensors are kind of very, very little developed. And the peroneals and also the gastrosoleus, posterior tip and flexors. So this is not a problem of one muscle in clubfoot. And I'm saying that specifically talking about anterior tip, as we will discuss, is a problem of development of the lower extremity and affects all the compartments from the knee down. Now, most people have seen some cases in which you do the casting, and then for reasons that is like, oh, you take the cast off and and then this much swelling, and everybody's puzzled because, oh, why this happened? Well, this happened for 2 reasons. One reason is because when you are doing the casting, you stretch too much, or you put the cast too tight. But there's no question that some cases, many cases don't swell up too much. There's a little puffiness, but it's okay, but others are not. The more And we don't know the genetics, but there might be several genes that are leading to what we call clubfoot. And what happened is that the neurovascular bundles also have a soft tissue around them. And when these cases are a little bit stiffer, and this is what happens usually when there are stiffer cases, those neurovascular bundles are also have a stiffening of the tissues, the soft tissues around them. And so when you are stretching the foot with your technique, then there might be some compression. And if I ask, you know, what do you think will be the problem with this swelling? Well, yeah, okay, you wait and let it go, but some people keep doing casting, and the cast comes off and so forth. And the problem is when you get this much swelling, the interchange of oxygen at the level of the muscles and soft tissues, but specifically the muscles, get decreased. Yeah, the artery is able to put blood into the leg, but the veins are and the lymphatic system had difficulties getting the blood out. And then there's an stasis in there. And then the oxygen is much less for these tissues. And this is extremely important, and also has tremendous implications on relapses, because what happened is that these two studies from the group of Matt Dobbs and Christina Burnett, they did an MRA of clubfoot, and you can see that there's sometimes abnormalities in the blood vessels. For people that did surgeries for many years, sometimes you get into big trouble because the circulation was not that great, and because there's potentially abnormalities in these blood vessels. And the results of these cases, and this is another study by the group of resistant club feet, feet that are very difficult and they swell up and it's very hard to get them around. You can see here, especially in the middle column, the amount of really necrosis of muscles that is produced. And you can imagine that these cases are not going to do very well in the long term. So, you know, clubfoot already has smaller muscles, and if you get into this kind of situation, then these muscles are suffering much more. And you can imagine that then the relapse rate in this case is much higher. Actually, in our statistics, it's about 60 to 70%, even using the brace. So this is a very, very important point that everybody has to take in mind. Swelling in clubfoot is tremendous, has tremendous implications for the follow-up and the outcome of these patients. Now, in this same study by Polito, they look at patients that have finished the treatment, and this was a 4 or 5 years old kid that finished the casting and the bracing. The leg looks very nice. It's a little thinner compared with the other one. And, you know, it looks about the same size, but when you do the MRI, you can see here that the muscles are about 50% smaller than the other side. Now, the fat is a little bit thicker. And so from the outside, it looks like it's about the same, but the inside, these muscles are not very well developed. And that is what it leads to relapses. And so relapses in clubfoot are coming because the muscles are not growing properly. And we are really very lucky that relapses, when you look at the number of relapses, and this is based on our own statistics, and we will talk a little bit more about that later in the lecture, in the talk. You can see relapses are very common in the first year of life. Then by the second year, it goes a little bit down, third year, fourth year, fifth year. And usually by 5 or 6 years, the number of relapses decrease very much. And actually the number for us in our statistics is about 5%. So after 6 years, there's about 5% of patients that might still tied up because those muscles still are a little bit tight. And so the reason for saying use the brace until 4 or 5 is because that way you can cut 90 to 95% of the relapses that you will see in your clinic. And why relapses grow? Well, happen. Well, you have a muscle and soft tissues that are a little stiffer than normal. And you have a bone, as we described, that has absolutely zero problems growing. The growth plates are growing normally and making the leg longer. And those muscles also has to grow. It's not that you stretch them, it's that they have to grow. And if they are a little bit stiffer, they will need more energy for growth. So this, the main factor for muscle growth in childhood is stretching. If you don't stretch the muscles, those muscles are not going to grow at the same rate that the bone is growing. And that is why relapses happen. So relapses in clubfoot has nothing to do with the foot. So thinking about how do I cut the foot, if I cut this ligament or the other one, if I lengthen this muscle or not, has absolutely nothing to do with the real cause of clubfoot, which is an abnormal, it's literally a slower growth of the muscles. But if you keep those muscles stretched properly, as with the energy that they require for growth, then those muscles will grow better, and then you won't see relapses. And I think this is critical for understanding clubfoot and for understanding the treatment of clubfoot, because the Ponseti method really is not a casting technique. The Ponseti method is a philosophy. It's an understanding of clubfoot and how do you approach clubfoot with the concepts of Ponseti. And the muscles that are the most important are the muscles in the posterior aspect of the leg, no question. So in a normal biomechanics study of the hind foot, how the foot moves and the hind foot moves, we know that the peroneus longus and brevis are evertors. It brings the foot out, and it's a little bit of help by the extensors. Now, everybody thinks that the posterior tip and the anterior tip are the strongest muscles inverting the foot. But the stronger muscle inverting the foot 5 times more is the soleus, because the soleus has a biomechanical advantage because it goes to the tip of the calcaneus, and just a little shortening on the soleus is 5 times more lever arm than the posterior tip. So relapses happen because the muscles start getting behind, they don't grow as much, and especially because the soleus, which is a very kind of interesting muscle, start getting shorter unless you keep stretching, and you have to stretch in dorsiflexion for the soleus. So the only way to get the soleus to be stretched is if you keep the soleus in dorsiflexion. And so a smaller amount of decreased growth in the soleus increases by 5 times compared with the other ones. So relapses are not initially driven by the anterior tip or the posterior tip. Relapses are driven by mostly the soleus not growing properly. And this is critical. And the key here is that this abnormality in the development of the limb stays with the life of the patient. In this MRI from the work of Ippolito, you can see here how the leg in this adult person, and he was treated with the Ponseti method after Dr. Ippolito went back to Rome, that the size of the muscles is half of the size of the normal side. Functionally, most people have no problems, but it's clear that this abnormality in the limb development and growth on clubfoot is abnormal. So this is why it's extremely important for people to understand that clubfoot is not a foot problem. Clubfoot is the result of a developmental abnormality of the limb affecting the muscles and soft tissues that by differential growth compared with the bones pull the foot into the clubfoot position. So clubfoot is really not a diagnosis. Clubfoot is just a symptom, and the symptom of a developmental abnormality of the leg. And if you don't understand this, you are going to make wrong decisions because you are going to concentrate your treatment in the foot. And how do I put it straight when the real abnormality is in the leg? And if you keep those muscles nice and stretched, the foot is going to be just in the right position with no problem. And this is critical to understand. So, as we discussed, the Ponseti method is really not a casting technique. The Ponseti method is actually what I will say is a philosophy. You know, it has a very specific way of manipulating, a very specific way of doing the casting, which is what most people understand. But it's a very specific way also preventing relapses, which is our topic today, and treating these relapses. As it's been said, most people feel comfortable doing the casting and getting the foot straight, more or less. And then people are facing the problem of relapses. But if you understand why this happened and you understand the muscle development, then you can actually understand the treatment of clubfoot and the clubfoot relapses. The key here is that the principles of the Ponseti method are very, very simple. Really, this is, you know, he was a genius on coming up with this method. And the principles are just three. I mean, really, you apply these principles to every single case of clubfoot, you are going to be successful. Number one, either for a 1-day-old baby or for a 10-year-old kid without relapse or for a 15-year-old person that never been treated, a neglected case, what you need to do first is stretch those muscles with your casting to get correction. Because you have to stretch those muscles to get correction. It's not cutting ligaments what is going to get correction. You have to get dorsiflexion because that's usually the last step. And you can try that to do with casting, but that puts a lot of pressure on the talus especially, and you can create iatrogenic deformity, which is a flat talus. And for those, you do a tenotomy. And then you maintain the correction. Once you have the foot corrected, means you have stretched all the soft tissues and muscles and tendons, then you have to maintain that correction. And that correction is maintained by bracing. And after the age of usually 4 or 5, then if in those 5 to 10% of the kids that still, there's a tendency for those muscles to tied up with growth because they are still not quite flexible, then you can add a tibialis anterior transfer. But this is very critical. The anterior tibial transfer is not to correct a relapse. The anterior transfer is to maintain the correction that you are doing with your casting and tenotomy. And this is critical to understand because I see a lot of cases, and I know that Monica and Christof see a lot of cases of patients that have been treated and they have done anterior tendon transfer and they keep relapsing. And they have a relapse, and so because they didn't do casting before, they didn't correct the deformity. So this is very, very important and very simple. Any deformity, you stretch and cast. You get dorsiflexion, and then you maintain with something, a brace or anterior tendon transfer. And with that, you can use it at any age. Now, it's very important also to think, and I think this is critical, that we all want to get from that to that. You want to get a kid that is born with clubfoot to a normal looking, flexible, not painful, normal, almost normal in function foot. And we all have 2 instruments to do that. We have our knowledge, and then we have our hand, and then we have a knife, or we have a plaster cast, okay? And the problem that I see in many places today is that when you decide to go with the surgery, you require a very special environment. You need an OR, you need a specialized pediatric anesthesiologist, you need an assistant, you need an instrument person that knows what he's doing, you need another nurse around. I mean, you need a team of 4 or 5 people besides the people in the pre-op and the post-op and then in the floor, right? And you don't dare to do this, to correct this deformity through surgery without that. And what happened frequently, more frequently than one would think, and I think this is one of the of those, difficult to understand situations in medicine, is that when you use the also very powerful instrument, which is the cast, because it's messy and it's just cast. I mean, it's like, oh, it's cast. Then it's done by the resident or the nurse or the physical therapist or somebody. So surgery is only done by associate professor up. Casting can be done by anyone. And the problem with that approach and with that really mistake, because what you are doing is treating clubfoot, no matter what instrument you use, and your knowledge and skill are so more important with one or the other. One has a set of problems and complications. The other one also has a set of problems and complications and results. If you don't spend and use the same detail with the casting as you do with your surgery, you are not going to be successful. And this is critical, because this is, I think, one of the major issues that I see today globally, is to minimize the value of the casting as an instrument to correct this deformity. And I think that is a wrong concept in the orthopedic community. I will say, and I will argue, that casting is probably as, if not more challenging, to correct 100% of the kids than knife. Because with a knife, you can correct anything. You just cut more or cut less. But with casting, it's much more difficult. And you start getting to swelling and sores and everything. It's just very, very, very hard. So it requires this mindset, and don't minimize. Actually, I think you have to make sure that the method is, and the technique is properly done. And this goes not only for just a baby, but this goes for any case, any neglected case, or any relapse at any age. So it's a teamwork. And as we were discussing, relapses is the most difficult thing that we see today. And as the poll show, is because of not complying with the brace. And as orthopedic surgeons, as Dr. Deeren said, we are blaming the parents. No, it's the fault of the parents. We are not in fault, it's the parents' fault. And that is a big problem. And it's true, it happened that way. But it happened that way because the parents have not understood the treatment and have not understood that they are part of the team. So when you see the baby in the first day of your visit, and then you start your casting, instead of letting the parents to sit in the corner in 2 chairs and mom is almost crying, and then you are doing this, or maybe even your resident is doing this and the kid's crying, and then every week you come back and they come back and it happen the same thing, those parents psychologically it's very hard for them to understand, that they are part of the treatment, and they have the most difficult part of the treatment, which is the bracing. So from day one, you have to get the parents to be part of the team. And they are the best persons to anesthetize the kid. They have to keep the kid nice and relaxed, because it's very difficult to do casting, either in a baby or in a 1-year-old or 1.5, kicking around because they are so excited. And they are the best to keep the kids calm. And so when they do that, and they are part of the team, they internalize the treatment and the outcomes. And that's the best way, and really the only way, to keep these families using the brace until the age of 5. If you don't do so, you are going to continue having problems of compliance. And the compliance is not coming from the parents, it's also coming from you, because you have not been able to make these parents understand the treatment completely. And that's why the Ponseti method is not just a casting technique. This is the whole interaction with the parents. The kids are not finish treatment until they are 18, and they finish. You see this all the time in every place. Short cast that fail, no molding at all. Just put something in the leg to see if you can stretch this thing. And I see this all the time, and I suppose that you also see this in your practices. And so then it's like, well, this foot is very rigid, it's not responding to the Ponseti, we need to go back to surgery, right? And then this is all kind of problems that you are going to see, especially with rocker bottom deformities. And you do an x-ray, the talus will be absolutely flat. And then you get into this swelling complex kind of situation with feet like these ones over here. That is like, how can you get to that from a kid that is so nice and soft? Well, this is a huge complication. And if you think about this and you look at the MRI of the cases with swelling, you're creating almost a compartment syndrome in this feet. And that's why they don't respond to the treatment. So this is very, very important to understand. And why I say this? Well, in this systematic review of the management of clubfoot by Chao Li Group in China, what they observe in clinical variations is like, oh, in my cases, no, in India, no, in Brazil, no, in Austria, no, in Iowa, the feet are not different. What is different is how do you apply the method? How much detail you put into your casting, how much detail you put into your bracing, how much coaching do you do to your families, and how do you, manage relapses. And the truth is that when you do the method properly, when you follow the guidelines, then the results are amazing. And this was demonstrated in this paper. The group of Matt Dobbs and the group in Denver here in the United States. In Denver, big children's hospital, 16 orthopedic surgeons. Probably there are more now. They are very busy. And then Matt Dobbs, he has a clubfoot clinic dedicated to clubfoot. And the 16 orthopedic surgeons, they will adapt the method to their understanding and to their practice. And so when they put the two together, what they realized is in Denver, they have a 50 to 60% surgery rate compared to no surgery with Matt Dobbs applying the method properly. And this is including extensive releases and so forth. So is how do you apply the method through the life of the kid is extremely important. And I can overemphasize this fact. It's not the feet. The genetic plays a role, as we saw, and they were right. The bracing plays a role. Correcting the foot completely plays a role. Not using the brace plays a role, huge, but this is all under your responsibility. Now, we did a study a couple of years ago. We asked the POSNA members, and we did a poll similar to what you did this morning, okay? And I'm so happy that the poll this morning in India is much better than the poll that was done in the United States with the POSNA members. Because what we found when we asked about the treatment of relapses is that only 34% of the people recommend the brace until 4. And when they have a relapse, and relapses were present up to 40% of the time, in many cases, half of the people didn't do casting, which is critical. You have to correct the deformity with cast before you do maintenance. And because you don't do that, and you go to do the anterior tendon transfer, the foot is not corrected, it's like, oh, we have to do something. And so surgical releases in this country are still done in almost half of the patients for relapses. And this is really outrageous, really, I would say. There was a paper by Science and the group in which United States, as you know, we have CPT codes for every operation we do, and then we have, as you do probably, and then we have the ICD-9, now ICD-10 for disease. So you cross two, clubfoot ICD and 10, and then you cross the codes, because here is all insurance companies and they pay you by the codes, really. Then this is all going to databases, and there's one database for a representation of all the children's hospitals in the country, okay? And Liu took a look of this early on and look at the number of surgeries in clubfoot from 96 to 2006. Remember, the first course of Ponseti method here in Iowa was in 1999. And so by 2000, you can see here that after 2000, when a few people in the United States start being trained, the number of surgeries over the next 5-6 years went down 85%. Now, this is surgeries in the first year of life. Okay, so it really tells you that by doing a good casting technique, you can really reduce the number of cases. It should be 0 if you do it correctly. I have not done any surgery, posterior release or nothing, in idiopathic clubfoot or here in Iowa for 30 years. So you can correct all the cases. I mean, some of them might take you 14 casts, but you can all turn it around. You can stretch those tissues slowly, but can be turned around. Now, we follow this study because our experience here in Iowa is that it was not that pretty. And what happened is that when we used the same database and we went to 2012 and now 2016, and we are just finishing up those statistics, so this is still not impressed, but I wanted to share with you. In black is the first year of life, and definitely, actually, there's a 92% reduction up to 2016 of surgery cases in clubfoot in this country. But the number of surgeries after 1 year of age is practically the same. And this is why, when you put this together with the POSNA membership questionnaire on relapses, that people just keep doing surgeries. And this is a big problem. And the type of surgeries that are done, and this is actual data, I mean, these are real hard data in the United States, is exactly the same than before the Ponseti method in 1997. And look at here one for external fixation, a peak at the age of 2. I mean, why do you have to do an external fixation in a 2-year-old kid that has a relapse? I mean, it's like, how that come? And doing osteotomies, from 2 years of age. There's absolutely no need for that, because it's not a problem of the foot, it's a problem of soft tissue. You have to stretch those soft tissues and maintain and stretch. So this is a big issue, it's still in the United States, and I think this is probably the same that you are seeing in India and other countries. And this is pretty cool. So we are pediatric. I'm a pediatric orthopedist, and then surgeon is kind of in quotes. But there are many pediatric orthopedic surgeons, and because you are a surgeon, you have to use your skills. And then doing surgery in clubfoot is pretty cool because it's kind of nice and delicate and then you get the foot turned around and it's beautiful. It's like, and you feel great about your work. The problem is that when you look at the data, and you look at until the patient is 18 years of age, which is when it's going to finish the growth, many patients by that time require 3 or 4 more surgeries. And I bet you that you have experience of cases that have 5, 6, 7, 10 surgeries because those feet are not very good. And the number of complications increments and increases with more surgeries, right? And then you have under corrections, you have overcorrections, and I can tell you overcorrection in clubfoot like this, and probably your experience, these are painful, really painful. So if you will look at the data, and this is clinical-based evidence, okay, not opinion experts' opinion, this is not tradition, you base your decision-making in evidence. These papers here, and sorry, it's a bit small, but I can share with you, it's in the internet. In blue is the long-term outcomes of patients with after surgery. In red is the patients treated with Ponseti. And you can see here that when you do a follow-up, and it's a 2 or 3 year follow-up when the kids are 10 to 15, most of the patients in these 3 or 4 papers, there's not too many, are doing pretty good. In general, they are okay. But once they reach maturity, 18 to 20, then the numbers goes down. And the last one, the longest follow-up is 30-year follow-up, 27, by the group of docs in San Luis, in which only 30% of the patients were doing okay, not excellent, some good, 30%, and then the rest were fair or poor. And the key here in this paper is that they combined only posterior releases and posterior-medial releases done in infancy when the kids were, 6 months, 10 months or something, because the results were the same. So no minimal surgery. I open a little bit in the back to get a little bit more dorsiflexion. In the long term, it has all the same effect based on this paper that if you do a posterior release. Because once you lock the calcaneus on moving and there's no dorsiflexion or inversion eversion because the scar in the back, the functional results are the same. Would you compare that with the red line, which is the Ponseti treatment treated patients, which are the Dr. Ponseti treatment back in the 50s, they stay in the 80 to 90% excellent or good results with a few fair and only 4 or 5 that have pain. So this is the dramatic difference when you are thinking about doing surgery in a patient with a clubfoot that we call. And the key here is that when you look at the same patients and you look at their quality of life, and this is a very important study, that component that Dr. Dobbs and the group did to use a quality questionnaire, nothing related with foot and ankle pain or scores or nothing. It's like, so how these people are doing in life. I mean, an SF36 is a questionnaire used for any disease to see the quality, to assess the quality of life of patients. In a normal person, it's 50 plus minus 3. We did the same on the Ponseti treated patients, and this is a 50-year follow-up, and it's 49. So people are 50, average 50, they are just doing fine like any other people. But 30 years old that were treated with surgery when they were kids, and then a few more surgeries after that, the majority of them had a quality of life of 33 points, which compares to chronic heart failure or Parkinson's disease in people with 60 or 70 years old. So these 30 years old people can do nothing. That is what this means. Because if they do something, they are going to hurt for a week. So they just decrease their level of activity to tolerance. But that is affecting their quality of life because they cannot play tennis, they cannot play football, they cannot do anything, or they cannot be hiking with their friends or nothing. And this is dramatic because these are 30 years old people. I mean, you are 60 or 70 and you can do hiking, it's okay. But at 30, I mean, that is really dramatically affecting. And it's not going to get better on these patients. It's going to probably get worse. So when you are thinking about treating clubfoot and you are thinking about doing anything that involves the joints and the ligaments and lengthening of tendons and producing more scar, please think again and think about these papers because you are setting that patient to a life of really almost disability. So what is the experience in Iowa about relapses? And this is a really interesting actual experience. So there are many papers out there. Many papers show huge amount of relapses as we were discussing. The most recent one by Science, actually, he reported a relapse rate of 68%, which is like, oh my. But there are many problems with these papers. One is that they are usually small cohorts, just 10, 15, 20 patients. One of the issues is that in many places, It's not the orthopedic surgeon, the one doing the casting and treating the patient, but other people, other providers, nurses or cast technicians or residents and so forth, which we can argue that maybe those cases are not as good as they should be. It's clear that there's deviation from the Ponseti method as we discussed, and there's a very quick going to surgery, as we have seen in the data here in this country. And most of these papers have no long-term follow-up. It's just a few years. And we know that in the first 10 or 15 years, most people do fine no matter what you do. So we look at all the patients treated by Dr. Ponseti and myself here in the University of Iowa. We stop at 13, and the study is underway, is almost done. So the patients will have at least 5 or 6 year follow-up. We have 1,000 patients, and this is not taking in account complex clubfoot. These are idiopathic clubfoot. They might have had some treatment, but they were not in the complex category, okay? And so almost 1,600 feet with more than 5 year follow-up. Statistically, you can see 2 to 3 more frequent in males and half bilateral, half right and left. So interestingly, over 65 years, we got exactly the same statistics that other people have in other series. With respect to relapse, in all these years, 2 things to make clear. No compliance with the brace is the key. And we, in 65 years, have a 12% relapse rate. And I think we worked really, really hard to get to this level. And you might be able to lower down, and that is great. And we try to lower this down, but it's kind of difficult to go down more than 10, 15%, because there are families that have difficulties in life and they need a lot of help. But if you are looking at the data and say, how can I do this the best? Well, you are in the 10, 15% relapse rate, you are doing very well. And that means that your period of bracing is working properly. Now, not using the brace is for sure a problem, and that is the main reason for relapses. Now, in the patients that have prior treatment, we have a little higher relapse rate, almost 20. And I think that's related to problems with the casting that is affecting the development of the muscles. And those muscles have even less flexibility because probably they have a little bit more fibrosis. And so they grow a little slower, and then you are going to see a few more relapses, but still is a manageable number. There was no difference statistically, but there's for sure those cases you have to keep watching and trying to get the family to go as long as they can with the bracing. Age at the presentation, as I said, previous treatment, 5 or 7 days, no difference. And even the number of casts for correction at the beginning has no difference. So if one case needs 5 casts, another one 10, if you get them corrected properly and you keep the bracing using properly, the relapse rate is controlled, okay? And just to point it out, because this I think is very important from the technical part of the casting, only 8%, 7.8% of all these patients in 65 years require more than 7 casts. So when you are thinking about clubfoot, and this is idiopathic, I'm not talking arthrogryposis or myelomeningocele. These are just normal kids. The one that we know is an idiopathic clubfoot. The only thing they have is a clubfoot, right? There's not much difference in these cases. 92% of them were corrected with 5 or 6 casts. Actually, our average is 5.3. So when you are thinking about clubfoot and you are blaming the foot because you are not able to correct them or you get too much swelling, you have to be very humble and realize that your casting technique or the way the casting is done in your clinic is probably not properly. And I think this is critical for people to understand. So how do you approach relapses? Well, we are in a very very tricky time. We are in a pandemic, and it's happening there, and it's happening in every single country. We have this virus thing that is killing the economies and is really making a huge impact in every one of us and in our lives and the life of everybody that we know. Now, as a doctor, you know, what you want is not to end up with thousands and thousands and thousands or millions of people in the ICU, which is super expensive, and many of the people don't make it, and there are thousands of thousands and thousands of people dying. What you want is to prevent that from happening by just using the mask, relatively social distance, and hopefully at some point we will get a vaccine and then things will get better, right? So the treatment here is not to be very complicated and I'm an ICU doctor and I'm great and I'm going to save the life of this person. Is like, you don't want people to get infected. Well, in relapses, in clubfoot, it's exactly the same. Relapses is not treatment of relapses. Relapses is prevention, prevention, and prevention. That's how you treat clubfoot. You are not treating to see what kind of surgery or technique or whether you cut or not cut and how you put the foot and the pins. What you want in clubfoot, when you are using the Ponseti method philosophy, is I want to prevent relapses and I don't want to do any surgery in any kid. So if I can go down to 0% tibialis anterior transfer, that will be the best. You won't be able to do that and you won't be able to get 0% relapses, but the lower, the better. So this is key. So this is the real Ponseti method. Anything else is not. And I think this is extremely important for everybody to understand. And because we are talking about relapses and we are talking about prevention of relapses, then what is the most important component and the principles for the brace? Well, the most important component and principle for the brace, besides that you put the affected side on 60 and 30 and you bend the bar and so forth, the key in bracing is comfortable shoes. That's the key. And a little baby, 2 months old, or a 1 year old, or a 5 years old, if you don't use a comfortable shoe, that kid is not going to be using the brace. And it's your responsibility, every one of you out there, and I don't know how many you are, but everyone, it's your responsibility as the doctor to provide the families with the most comfortable brace that is in your market. And if there is no one, you have to find one, because that's the key for success. You cannot just write a prescription, send it to the orthotic people and say, make a brace for this patient and come back in 3 months and see that the kid has sores and they are not using the brace. The family hates the thing and the kid doesn't want to use it, and then you are in relapses. You as the doctor are responsible for giving this family, and this kid, who is responsibility to get to 18 years old without problems, the brace that has the most comfortable shoes. That's the key, because the other things are just technical. 60 degrees here, 30 degrees there, bending the bar or no bending the bar. And I can overemphasize how important this is. So please, when you are now back in your clinic tomorrow, you look at what are the options you have, and you start looking for one option that provides those parents with the most comfortable shoes for the kids so they can be successful with you. That's the way you treat relapses, is preventing them by using a brace that is comfortable. There's no other way around, really, no other way around. And there are many ways, and there are many shoes out there, and many braces done by many people. And I would say that if you will have a kid with clubfoot and you have to use some of these braces out here, it will last 2 weeks for you and your wife to get desperate, because your kid, and just think about your son or your daughter using these things for 4 or 5 years. There's no way unless they are comfortable. And what type of brace is also very important, right? And you need to stretch those muscles. That's the function of the brace. The function of the brace is not to hold the foot. And that's why this concept of clubfoot is not the best concept that we can use. It's a developmental normality, and you have to stretch those muscles because the foot is going to follow what the muscles are saying. And so the key here is that the kid should be free every day, during the day, running, because that's the best exercise for those muscles to grow. And then at night, when those muscles are relaxed, and also when the kids grow, which is at night, physically, they grow, then you have a brace that is stretching those muscles. And the key one, besides the posterior T, anterior T, and flexors, which you require abduction, is the soleus. And the brace is not holding the foot. It's not something to hold the foot in position. The brace is something that is dynamic, that allows the kid to be moving and stretching through the night when they are moving around. So any AFO, any plastic that you put during the day or at night is affecting the development of those muscles. So you don't need anything, no inserts, no nothing. Just let the kid grow and run as much as possible, because the more they run, the better it's going to be the muscle development and the elasticity. In this study, this was an investigation for a PhD, and they developed this model. And in a nutshell, here in the top is the standard brace. I hope that you can see it. And you can see that all the muscles are stretched other than the peroneals and the anterior tip, because if you keep the foot in abduction, the peroneals don't get stretched. They shorten a little, and the anterior tip also is a little off the axis of movement. If you use an AFO, yes, you stretch a little bit up to 90 degrees, but you are not doing dorsiflexion. And if you do dorsiflexion, you start having a relapse. And then if you use the articulated brace, the DOS bar specifically in this study, because the DOS bar has too much flexibility and it can go in plantar flexion. Yes, it stretches the posterior tip and the flexors and the anterior tip so on, but it doesn't stretch the soleus as much because the kid can overcome the flexion. And so it's not as effective in this model as is for stretching the feet. And another thing is very important, and this is a paper from Norway, is that if you use an AFO at night, it's like, okay, during the day the kid is running, but at night we are going to put a brace to do dorsiflexion and a little bit abduction. So this is a model that is very much in use in the Northern Europe, Norway, Sweden, Germany, and in many other places. And here in the United States, it's called the Wheaton brace, and probably you have other names. So it's an articulated AFO with the knee also included, the thigh, and then you have these straps. And well, when you are doing that for 10 to 12 hours for 5 years in a kid, what is happening is all those pressures, and you are not allowing, like in the standard brace, for the kid to be moving, because the brace is not holding the foot in position, it's just allowing the muscles to stretch in the right direction, which is different. Then the number of flat talus is, mild, moderate, and severe is 90%. So if you put a brace putting pressure on that talus by using this kind of brace, you are flattening the talus. And you flatten the talus, this person is never, ever, ever going to have dorsiflexion in that foot. It will be neutral or less. And you are going to be fighting even more the growth of the muscles until the patient is 18. So the best brace biomechanically and the best brace functionally, based on this information, is a foot abduction brace that allows the kid to move around without any pressure, with the most comfortable shoes that can be done for that kid. And that's the way you prevent relapses. So how to enhance compliance? Well, number one, make it fun. Don't think that the braces are a punishment. Don't let the families from day one to think that this is a punishment. This is a very positive thing to keep your kid out of trouble. They need to have the tools to be good. And if you recommend a brace that is so painful because it's so hard or doesn't fit or something, and the foot is not fully corrected, and on and on and on, those parents are not going to be successful. I don't know if there are parents that don't want the kid to be successful and be fine. It's your responsibility. And understand where are the problems. Sometimes they have another kid. Mom, is pregnant, and then they have 3 kids, and the father is working very hard, and they are with grandma, and grandma feels so bad because you have to put the brace in the baby. Oh, poor baby, something. I mean, these are real issues, but you are the doctor, and it's your responsibility to talk to the parents and make sure that they understand this, and they do if you are a coach for them. And I think the best position for you as a doctor to prevent relapses is to be a coach, like the coach of the football team. There will be bad days, and then you have to regroup, and there will be very good days, and you have to tell the parents how well they are doing when they come back to clinic, because they need that, right? And relapses happen clinically. Now getting more technical, remember there is this muscle development issue. So the sign of a relapse is that you start losing dorsiflexion because that gastrosoleus is getting tight, okay? There's no relapses caused by dynamic supination of the anterior tip. Very few, 5 in my cases, very few. They are always have tightness because that's the muscle growth of the whole leg. Remember in that MRI that the anterior tip was tiny, little, and with the MRI characteristics of, having fibrosis or fat in between or something. So the anterior tip is not super dynamic here. It's not super strong, actually. It's just the same as the other muscles. It's stiff. So always look for how much dorsiflexion and abduction you have on the feet. And when you start getting a relapse, besides losing dorsiflexion, what that means is the calcaneus start going into plantar flexion. When it does that, biomechanically, you remember from Dr. Ponseti functional anatomy studies, it start turning in and going plantar flexion and inversion. So that start giving you the varus, and it start giving you the adductors of the foot, no metatarsus adductors, adductors of the foot, and then eventually the foot will start developing a little bit of cavus. So in the early stages of a relapse, you might only see a little bit of loss of dorsiflexion. If it is more time between stopping the brace and when you see the patient, those muscles are going to tighten up more over the growth of the patient, and there's going to be more deformity. And the kid will start walking on the outside of the foot. Like in this case is a 4 or 5 years old kid, and he came 6 or 7 months after stopping the brace. And you can see here that it has a little varus, it start developing a little bit of cavus. The foot is turning in, and here we don't examine the dorsiflexion, but there's no dorsiflexion. So that is how a relapse happens, is because all those muscles over a period of time, the bone keeps growing, they get behind, they start getting tight, and then they start making the foot to turn in. So how do you treat relapses then? Well, it's the same thing. Number one, you stretch those tissues by casting. The same thing that you did when the newborn baby was baby. And then you do a tenotomy or not, depending if you can stretch them completely. So if the relapse is kind of not too advanced, then you might be able with 2 or 3 casts to get dorsiflexion, and then you go back to the brace. If it is very, very stiff, or the patient came when he was a baby and then they don't show up until 1.5 years, and then the foot is almost the same as the original deformity, then you just follow the program. You just do the casting, do the tenotomy, get to 10 to 15 degrees dorsiflexion, and then go to the brace until the age of 4 or 5. And if you do that, 90 to 95% of the patients don't have a relapse. And that's the way to treat relapses. And after the age of 4 or 5, if it is very difficult for those patients to usually is because they are old enough and they learn how to take the shoes and so forth, then after you correct the deformity with casting, then you do a tenotomy and anterior tendon transfer on at the same time. And that is the treatment for relapses in those 5% after 4 in general. Now, I would like to ask with this part, what will be the opinion of the panel about this case? He was 10, 9/11, and he had 5 casts and tenotomy done by Dr. Ponseti. The family used the brace until 3, so not too bad. They start noticing that it was start getting tight by 5 or 6. They didn't have insurance, which is unfortunately common in our country. And he presented at 10 with this deformity. And let me go to the lateral side. So he was walking like that at the age of 9. So I would like to ask the panel, what will be their approach on this case?
Okay, let's start with the Indian faculty first. The Viraj, you being youngest of the expert, what will be your opinion?
Yeah, I would still like to go ahead with, as Dr. Jose mentioned, some casting, and if and some kind of mini invasive procedure like for correct, because there is a lot of cavus. If you see, the cavus is still there, so cavus has recurred. So maybe percutaneous plantar fasciotomy, and then followed by the tenotomy and the same sitting. And if it is required, I may go ahead with some kind of osteotomy like Lichbla or Evans, like some maybe a simple cuboid wedge dissection if it is not responding to the casting alone. So that
For how many casts you will wait before you go for the osteotomy?
Considering this child is 10-year-old, I think maybe around 3 or 4 or maybe 4 or 5 should be sufficient, not more than that, with considering the amount of deformity what the child has.
Okay. Monica, what will be your take for this? How will you manage?
Well, I know this case, so it's not fair. But I think the most important thing to consider is that if you go on Ponseti method again, you have to be sure that you are making progress. I think this is crucial on the grown-ups or neglected, abandoned cases after walking age or relapsed. You have to be sure that you have a control of how your cats are abducting, how much they are abducting, and if you got stuck in something, so that one, you can revise your technique and improve and get going, or you stop and do something else. But to remember, this case has no previous release, has no other incisions. Absolutely. So things must be good if you go on Ponseti. I think you have a tremendous advantage than not having messed with all the structures, and you should get stretched if you go well with the Ponseti. So I won't say because I know the case, but just go for it and control if you're doing good progress. I think that's the clue.
Yes, John, for your opinion. But before that, how many number of blasters do you anticipate in this case at the age of 10? Because parents will usually ask like how many blasters we have to come. So what will be your answer or explanation to them? Yeah, Monica, what will be your explanation to?
Well, you have to tell family because they have to plan for treatment. Okay, so I will throw 6 as a good number because that's more or less the number of the babies. So the family has to give you 6 weeks and let's see what happens. And if everything is very, very good, what happens? If you have to go one or two more and you finished, and you ready for tenotomy and anterior tib transfer, it's a good thing. But you have to make a plan. If you get stuck on some number of casts, that's not bad. You have to revise, see what's going on, and replan or ask for help. Both opinions are okay. And I think you have to give the family some, instructions. So, okay, let me have this protocol for this 1.5 months, or maybe 2 if they are from far away. And you see what's going on, and you document, and this way you can see if you're making progress.
Okay, but then they usually ask in our country, what will be the success rate? So of the treatment which you are offering. So what will be your say to that? Like, how would you promise to the family about the result?
Well, you have to tell them that you're treating the foot. So you have to be ready to get. I think this
sound is not great.
It's very important. But people start those treatments without having this back. Sorry. Can you hear?
Yeah, yeah.
It's
so
patchy.
You have to be sure that hospital is available. Hospital is available. This is a way that you can do Ponseti method only if you can or not. Yes?
Yeah.
Right. Yeah. John, what would you like tell to the family?
I would certainly, I think I more or less agree with what Monica said, is that certainly would try casting again. And again, go the same way, because supination again is a question of getting the sort of cavus is a question of supinating the forefoot so that it comes in line with the hindfoot. Okay. And then do your casting the classical way. And obviously you need to see the progress. You can't say every one of them will do well, but we've done quite a few older kids up to the age of 12, 13 with Ponseti casting, and especially if they've not had major surgery before, like posteromedial releases, etc. It still works quite well. Okay. So go the same way. Maybe more castings may be necessary. You may need 8 or 10 castings sometime. But if you're progressing in your first 4 or 5 casts, then I would continue doing that and go on with that.
Okay. And yes, Christof, what will be your take for this? Like anything different than what Monica said, or the Viraj or the John said?
I think most things have been said. I think a very important point is the quality of previous treatment. So if there was no surgery before, if it was casted well, then you can expect a very good result from recasting. I think one important fact is sometimes, I mean, you really need to palpate the foot and to feel the foot.
Yeah.
It's difficult to say from the pictures. Some feet like this, they might only need like 3 casts or something, and some feet might be more stiff. But I think then in the end, you really need to look at the result of your casting before you think about percutaneous fasciotomy of the plantar fascia, or if you need a transfer or not.
Okay. Yes, Jos, before you show us the result, one question by the participants. Is there a role of physiotherapy in this case?
Not really. I mean, you can, if they are during the bracing time, there's no need, because there are 10 hours of stretch by the brace. I think there might be a role when the patient stops the bracing around 5 to get into the habit of doing stretching exercises, mostly for the Achilles tendon. And so learning with a therapist how to do that and control from time to time. But there's no, I don't think there's a need for, in general, for formal physical therapy. Usually I recommend a home therapy program. So the patient learn the exercises and then they do it at home, and then every so often they go to therapy to see, you know, if things are okay.
Okay, then there was a very important question by Tariq Sheikh. He has asked that how a 10-year-old child can tolerate a above knee plaster.
Well, that's a very good question. You know, actually, one of the issues here is what kind of, how high the plaster goes. If you go below the knee or you go above the knee, okay, in relapses. If there's only some tightness of the heel cord and a little bit of cables, not too much, and the foot is, you can get the foot to neutral or even 10 degrees abduction, so it's a kind of early relapse. You can use short leg cast, let the kid walk, and usually with that you are able to stretch the foot nicely with probably 2 or 3 casts at the most and go back to the brace. In cases in which the deformity has more stiffness, or in this case, long leg cast works better because you can hold the foot as you are progressing on your abduction. You don't need to go to the groin. You just go just a little bit above the knee. You can let the knee, instead of 90 degrees, like 60 or something, so they can still walk. It's no question that it's kind of difficult for the kids and the families. But you know, but when you put it on the whole scheme, anything that you will be doing, they are going to be for 3 months in casting or fixator or something anyway. So it doesn't make it much longer than that.
Okay, and is there a role of Botox, botulinum injection in this by weakening the gastrosoleus muscle? Do we get a faster correction?
So this is a question that you know, you have to think about the pathology again, okay? And that's why I started with half of the presentation on understanding clubfoot. Clubfoot is not an spastic foot. Clubfoot is that the muscles are tighter. They have some fibrosis built in, right? So what it makes the muscles not to have enough flexibility is not a spasticity because the nerve is sending too much signal to these muscles, is because they are stiffer. So if you use Botox, it's not going to do anything because Botox is not going to treat that fibrosis, right? So there's no, I don't think there's absolutely no role because Botox is for inhibiting, you know, blocking the neuromuscular junction, which in these cases, the rest of the muscle is completely stiff, right? So it has, in my opinion, it has no value.
Okay, then there was, before you show us what you did, there was another question. Is there a role of X-rays, radiology to evaluate the deformity, or it's just on a clinical ground, we evaluate the deformity?
I mean, you know, I think you can do X-rays, like in this case. You know, I think you can do X-rays just in case. We know the story because it was one of our patients. We know that he had just regular clubfoot and used the brace, and we saw him when he was maybe 3 or 4 and he was doing okay. So it's not like, you know that there might be some weird fusion or something because he was fine. If it's a patient that comes from somewhere for me, like this patient comes from somewhere and shows up the first day in my clinic, then most likely I will do an X-ray. I mean, the X-ray is mostly to rule out any, you know, like fusion or something weird, but this is a soft tissue problem. Remember, I mean, this is the key of the whole presentation. This is not in the bones. The bones are moving depending on how the muscles are pulling them. And so you took an X-ray and yes, the bones are going to be looking weird, you know, but it's because the muscles are tight. So other than rule out some kind of weird bony stuff, I don't think there's no really need for X-rays or X-rays in every case that you have a relapse.
Okay, then there was another important question that the primary problem of this relapse is because of the lack of compliance. Now, even if we correct it, poor compliance is going to be there. Will it not lead to a recurrence subsequently?
Well, in this case, you know, he's 10 years old. So, I mean, he was compliant until 3, which is, you know, not too bad. And he did it relapse right away. So this is one of those cases in which the muscles are not too stiff, but over time, they still have, they get behind the bone, okay, in the growth. So at this age, going back to braces is, I would say, I mean, it can be done, but it's very, very hard. And then after 4 or 5, if it will be at 2 years old, I would say, yes, it's lack of compliance. But we have been talking about compliance. The patient, the foot has to be corrected, and the family has to have a brace that is comfortable, and you have to educate the family to use the brace. And that's your function, and that's your responsibility, because it's your treatment. They are treating the patient for you. You are responsible to that kid, because the one in the chart is the name of the kid, it's not the name of the parents. So your treatment for that kid is through the parents. So you have to provide the parents with the tools to be successful. So I can overemphasize that comfortable shoes is the key, and educating the families. And so usually up to 5, most kids are okay coming back. After 5, 6 is kind of hard. I have some that can get to 7 or 8, but it's very, very difficult. So in these cases, then you have to go to the other pathway, to the other maintenance, which is the anterior tendon transfer.
Okay, let's see what
do
you did in the...
Yeah.
So just, so how would you brace this kid post-treatment? Nothing?
There's no need for bracing after the anterior tendon transfer if it is done properly. Okay. So, so this case, this is how it looks like after 5 casts. And, the casting was done above the knee. This is not a cast that is kind of easy. You have to be very careful, like in any cast in clubfoot. If it is the first cast that you are doing in your life, I can guarantee you that you are not going to get correction. You have to spend more time doing the manipulation, doing the stretches. It's kind of 3, 4, 5 minutes. You have to be the kids can respond to you. So you ask them and you push. And what's going to happen is that, as John said, actually, the first and second cast, sometimes you don't get that much correction because those muscles are stiff. But there's one thing that works in our favor in clubfoot, is that when you put a cast in a leg, any arm, after 2 or 3 weeks, there's atrophy, right? And that atrophy makes things softer. So in these cases, and the same thing for youngers, the youngers are more flexible, so usually it's more predictable. But after 5 or 6, and we are talking about only 10% of the patients, right? Okay, then after the second cast, then you start seeing that you get more correction, because that atrophy is helping you. And usually, as Monica said, I mean, every case is different, but this is one of the cases that are pretty bad looking. I mean, it's like, 5 or 6 casts, 7 casts, maybe 5 to 7 is usually enough. But the casting technique, the manipulation, and the feeling of how you hold and how you mold, and the cast that you use is critical. I mean, and in some hands might take 8 casts because you don't have good casting. The cast takes too long to dry. I mean, there are other factors, okay? But if you have a good cast, you have a good technique, and then usually 5 to 7 casts in relapses is enough. So we did that, and after we get the foot corrected, it means all the tissues are stretched. Then we did an anterior tendon transfer, a percutaneous tenotomy of the plantar fascia. There's no need to cut a lot. And then in this case, we did a Achilles lengthening, open, although you can do it also in a different ways, as we say. And this is about 4 months after the patient had the surgery. And you can see here that he has a very nice gait. The foot opens up. The heel is in neutralish. This is only 3 months. It gets better actually after 6 or 8 months. He can walk on the heels, so he has about 10 degrees of dorsiflexion, and the patient is doing okay. So even at this age, and I put this case specifically because a 2-3 years old is, a piece of cake. But even in older patients, and this is kind of the highest you can get, because this is only like 5% of the cases after 6, you can get the feet corrected without having to do any other surgery. If you will do any soft tissue releases in these patients, they will get very stiff and they will have problems that we saw before through their life, really, for sure. So,
sorry, Jose, I just wanted to ask you that in some of these late sort of relapses, we start with above knee cast for the first 2-3 casts and then change it to a shorter cast which they can walk in. Is that reasonable, or you feel that is not?
Personally, I think you get more correction with longer casts.
Yeah. But
unless it's as I said, if it's just a mild relapse, then you can go short, and with 2 or 3 casts, you feel that with 2 or 3 casts you can get a stretch. Short leg cast is okay. If you feel that it's not enough, long leg cast is better, and it might cut the number of casts that you have to do, because you.
What I was saying is what I was saying was you start with long leg casts to get the initial correction or get more correction initially, and then maybe by the 3rd or 4th cast you change it to a short cast in which the child can walk a bit better. Is that?
Yeah, I mean, I think you have to look at if that doesn't add 3 more casts for your correction, and you get a good correction.
Yeah.
Okay. And it's very difficult
because we do that because
stretch the medial side and the cables with a short leg cast. Then it's okay. But I think and also the families are coming back and forth and everything. So every trip that you save to that family is very important for them, and also it's important for you. I mean, this cast, is a 20-30 minutes deal. Yeah. And if you save 2 casts, you are saving, 20-30 minutes of your clinic to do another cast in a different kid or see 3-5 more patients. So it makes your clinic more efficient. So that's why the casting technique, you have to maximize your casting and the effectivity of the casting effectively. That's the key. So for the tenotomy, you can do just a percutaneous tenotomy, or you can do a hook procedure. I have done tenotomies until 7 or 8. There's a tenotomy, and they heal fine. After that, I don't know, I have maybe 20 cases of this kind of old cases. This case that I just showed you, the patient is now 25. So we did it many years ago, and we did a formal lengthening. But now you can do the hook procedure that gives you the same. It's critical in these cases, especially in these older ones, to do the casting until you pass neutral with your casting. If you are not neutral, the tenotomy or even the lengthening is not to give you 10 degrees of dorsiflexion. And the reason is because it's not only the Achilles, the soleus that is tight, the gastrosoleus, it's all of the other tendons and the capsule. So you have to stress the whole soft tissues and muscles with your casting. So don't do the tenotomy, or don't decide to do the surgery, which the tenotomy is part of, until you get neutral or 5 degrees of dorsiflexion. This is critical, okay? The technique for the transfer was originally described by Garceau in 40s, but it used to take it out on the ankle and then go to the 5th metatarsal. And I think this is from you, this is slide, Chris. And this is for you, Chris. So you find the medial side where the tendon is with a 2.5 centimeters incision. When you release the tendon, don't release it just here. You have to go and get those 6 or 7 millimeters around the first cuneiform and the first metatarsal, because those are the ones who are going to get into the hole for the transfer, okay? And when you open, never cut with your scissors all the way up, because you will cut the retinaculum and then you will get a bowstringing, okay? And then you find the 3rd cuneiform and with a K-wire or something, and then you drill a hole and then you suture the bone. I use non-resorbable. Personally, I like the more natural way. Usually I use a non-resorbable stitch. I did Vicryl, resorbable 2 or 3 times. And after 6 weeks in the cast, the bottom got loose because the Vicryl started getting dissolved, and then the family freaked out because, you know, they thought that the tendon would be loose. So from that day, I use non-resorbable Ethibond or Tech Deck number 2 usually, and I do crisscross. You don't need to do one of those fancy ones, and the reason for that is you just do a Bunnell, you know, crisscross, and the slide and the stitch slides. When you take out the cast and you cut the bottom, if you cut one of the strings and then you pull, all the stitch comes out. And so that way is the most natural way to let the tendon heal into the bone with no foreign body. Because anytime you have a foreign body, it's going to create a reaction by the body. And especially if it is a suture, and potentially can affect that tendon integration into the bone. And so that's why I prefer, number 1, to use not resorbable sutures, and then to use a suture that by cutting one string, you pull down and everything comes out, and then the foot is as natural as it can be. Now, this is a beautiful study by Christof, in which he was studying when you do the drilling, and you know, where are the structures that are affected, and we have the plantar nerves and arteries and there. And he found out, and this is critical when you do this, is that, you know, the nerves are just right there where the hole is coming. And so he found that when you do 20 degrees or so on the frontal plane, and on the lateral plane about 4 degrees, and you aim to the center, that's the best way to save, you know, those structures from being affected by the technique. And I think this is very important. This is critical. So this is relapses. So the truth is that you can treat all the relapses, really, prevent them with the casting, with the bracing, and then treat them with the casting and tenotomy and in idiopathic clubfoot and anterior tendon transfer. And in general, you don't need to use braces after that. To their question about physiotherapy, they benefit from physiotherapy after the transfers for maybe a month or 2 to regain a little bit of the flexibility, and because they've been in a cast maybe 5 or 6 weeks before, and then 6 weeks of the casting of the tenotomy and tendon transfer. And very few kids really need any braces after that. But I will ask also the panel, what is their experience on bracing after the transfer?
Yes, Monica, what do you think? Like, how do you manage the patient post-operatively? You have said something in the chat. So can you just tell us, like, how do you manage the patient post-operatively?
Well, one time I had finished my surgery, and you always let the patient go after 6 weeks in casts, and some of those feet are just too stiff. They are corrected, but you are afraid that as you wait for the tendon, the anterior tendon to be strong, there will be a loss of flexibility. So Morcuende told me to use the brace at night for 3 months. And that's my protocol after that. And that helps a lot because, one, it's very easy to use the brace because the foot are so soft and no problem at all. A family wants to do everything right because the surgery has already been there. So it's a good thing. And after 3 months, normally you let them go and fine, no problem, after the anterior tip transfer, okay? But for some feet, you have to bring the brace back for some time. If you see that lost a lot of a lot of dorsiflexion. So you reintroduce the brace as the best physical therapy. It's not bad for the physical therapist. Actually, they had a very important, way of helping increasing the peroneal tendons, because the peroneal tendons have been sleeping for a long time, and you need them to rebalance the foot. So it's a good idea to do to wake up the peroneal tendons. So after chip tendon has been my protocol since Morcuende gave me this tip, is 2-3 months at night, and then you see what's going on. If you don't do the tendon transfer, it's 1 year at night, even on the grown-ups. We'll be discussing here and there in the groups on the grown-ups. And actually, they are so happy that the feet are corrected, that the families will be able, yes, to fit on the protocol and use the braces at night. So I don't see difficulties to have these people using the braces at night, even for grown-ups. And it's just for sleeping, right? It's 9-10 hours maximum. So it's not a big deal. So that has been our protocol, and I think it for the grown-ups helps a lot, because if you don't have the transfer, you don't have 6 weeks waiting on the cast, and you need more time for remodeling. So it's very important.
So you use these even in the older children above 10. You use the foot abduction braces at night.
Yes. People come to see those cases, and they see the patients themselves putting on the laces and the braces, and that's not a big deal. And really, because it's part of treatment. I think one of the things that we don't talk about in this lecture, the lecture was amazing, Jose. We were fantastic, because it's everything about understanding, is that don't touch the foot until you talk to the family, because you have to identify the barriers and the problems that you had before, because you don't want this child again through the same problems that you had before. So talk to the family for them to understand, if they didn't understand what's going on with the foot. And it's not the Ponseti method, it's not the way of treating, it's the foot, the personality of the foot that behaves like that. So you have to make them understand, and there's not, they cannot choose part of the treatment and not the other. It's like a cardiac medication. You cannot choose the taste, that's it. So I don't want this, so you don't come for treatment. I mean, it's very, we've been so paternalistic, trying to be nice to the parents and to adapt, and we lose our good results. And then they're very predictable. So if you start to change, make concessions, and okay, that's fine. You don't like this, you don't like the cast higher up, so I'll put a little down. So I mean, if you are more cheetah in the sense of doing everything as it should be done, families will believe you more. You are more consistent, and the treatment will go smoother. What do you think, Chris?
No, I absolutely agree. I think that's a very important point. So, I mean, for some things, there is no plan B. And this is something I think the families need to understand, and that's something that we need to communicate. I think it's very bad if we always say like, well, if you don't, maybe we could do something else. I think there is no plan B for this kind of treatment and what we are doing. For the transfer, what I usually do, I have them in a above the knee cast for 4 weeks. And then I change the cast to a below the knee cast so that they can start to walk with the cast, because I think that's something that makes the transition to walking a little bit easier, because they need quite some time to get into walking again, to be able to weight bear. So this 2 weeks walking with the cast, I think, makes this a little bit easier. And I think, of course, I think some stretching afterwards is important. So we cut the Achilles tendon, but that's the thing. The other structures there, they can still prevent more dorsiflexion. So I think it makes sense in some cases when you're not so satisfied with dorsiflexion to use a brace for a short time, certain time, to stretch these other structures, and of course to do some stretching exercises.
Okay, the last question, because like we have already overshoot the time, we will be skipping the case discussion. But one question which one of the participants was asking is, if there is a edematous feet during the plaster treatment, how do we manage? Do we give a rest for the cast, or like there is some difference in the treatment?
If there is what?
Edema.
You talked about the swelling.
Swelling.
You showed that case where there was a lot of swelling, and you said that affects the prognosis.
Yeah, the swelling doesn't come just because it wants to make your life miserable, right? The swelling happens because your casting technique, for one reason or another, is not being proper. And so everybody has to really understand that. It's not the foot, it's your casting technique. So, but if you get to a point, I mean, and I have, you know, a number of cases that they swell up a little bit. If it is a little bit of swelling, usually you can manage with the casting. That cast is actually very tricky, and that's why you need somebody to help you, and not changing every day if you can. In a clubfoot clinic, it's like in the OR. You have to put the cast with a little tension, like it would be kind of a compressive bandage, not too much, not too little, and so trying to squeeze that edema. And usually you do that by next week is okay. If it is a little bit more, then the best is to just wait for a week or 10 days and then start. And then the next time you start, you know, you have to understand you have to be more careful, and you have to be careful with your stretch. You have to be careful with your stretching the cast in the last moment of getting, because you can stretch a little bit and then you grab it and then you're trying to push it and it's not going to go. So in those cases, you know, it's a warning for you to say, well, we didn't do it right the first time, and let's make it so it happened better. So the casting technique is really critical. It's not easy. I mean, being simple doesn't mean that the casting technique in the Ponseti to do it properly is easy. It takes a lot of practice. And I'm going to give you one, just a real life thing. Dr. Ponseti was about 90, and we were working together. I worked with him until he passed away. And one day we were doing the casting in one case, and he was about 90, and he was sitting doing the casting, turn around and say, you know, I feel now that I can do a good casting for clubfoot. And this is real. So, and this is Dr. Ponseti, 95 years doing casting. So it's not an easy cast. It's not easy. And the complications are iatrogenic complications of your casting. And so it's very critical that everybody develop the right skills for the casting. Otherwise, it's not that the Ponseti method doesn't work. It's that when applied properly, it actually works all the time. Very rarely, you cannot turn a foot around. I mean, in my experience, I never had that chance unless it was a weird thing.
Okay, so with that, Jos, no, Viraj, now we will be ending the session because we are already 15 minutes overdue. So now I request Dr. Venkat to have a vote of thanks. Dr. Venkat.
Good evening, everybody. On behalf of POSI, I would like to thank today's guest speaker, Dr. Jose Morcuende, for absolutely fantastic overview on Ponseti's technique. You rightly mentioned that you emphasized the fact that Ponseti is a philosophy by itself and not just a casting technique. It was amazing. And I also like to thank the panelists, Dr. Chris, Monica, and our own national panelist, Dr. Viraj and Dr. John Mukhopadhyaya. And just to summarize the things, Dr. Jose, today the theme was about relapse club feet, and he rightly said that prevention should be the first aim, and you try to prevent the relapse. That was the main thing in his lecture, and he also said that as a surgeon, you have to owe the responsibility that the child should wear the brace, and he said that he should make sure you choose the right comfortable shoes so that the child wears the shoes. And then he, of course, in the best of the hands, he said that they have a relapse rate of about 12%, and we should accept that about 10 to 15% relapse is going to happen, and then we treat the relapses following the same principles of PONCT, like stretching and casting, followed by tenotomy, and then bracing and tibialis anterior transfer. Thank you so much for the wonderful lecture and discussion. And I also would like to thank Ortho TV for sponsoring this event. Thank you, one and all.
Thank you. Bye-bye.
Bye.
Bye.
Bye. Yeah, Josh, what I would suggest is like still you had 2 or 3 case discussion, and our Indian experts also had a case discussion. So can we have a second part of the session later on, like say after 2 or 3 months?
Yes, absolutely. That would be perfect.
Yeah, because like what you said today is really something very important, that you really have to be after fit. It's not like that the first relapse you straightway go for surgery. So that philosophy is really difficult for us to accept. So probably 2 or 3 more case example and more interaction will definitely help us.
Perfect. I will be happy, and we will be happy to share. Actually, what we can do is to share cases, the 3 of us, so people can see, real life.
Yeah. Okay. Thank you very much. Thank you, Christof, and thank you, Monica.
Good night for you.
Bye.
Yeah,
Bye.
good night, and yes,
you.
good day for you.
Bye.
Thank you. Bye-bye. Bye.
Okay, bye.
Bye. Bye. Yes, Ashok. Thank you.
Thank you, sir.
Yeah, recording થયું છે ને આખું